Hi, I'm Dr. Metwally. I'm a joint replacement specialist for hip and knee replacement. I graduated from Mayo Clinic, where I have my special training in that regard. Today, I want to talk to you about my preoperative summary that I give my patients for total knee replacement. In my practice, I do a variety of total knee replacements. I do robotic-assisted total knee replacement. I also do a custom-made total knee replacement. For each patient, they have to qualify for certain criteria to fit in one category versus the other. And also in my practice, I do partial knee replacements, which about 15% of patients that come to my practice that might fit into that category. So it's not as common. And obviously a patient and a doctor have to be very careful to make sure that they choose the right person for a partial knee replacement. As far as the preoperative summary that I give my patients for a total knee replacement, I usually tell them that this is a very successful operation, and about 98% of patients will have improvement of their quality of life and activity of daily living. 97% of patients would wish that they have done it sooner because they're quite satisfied with the outcome. 95% of patients will go through it without major complication. As we all know, any operation carries some risk. And the risk collectively is about 5%. If you look at the ones that we really worry about the most, is usually infection. Infection is about 0.5% for all comers, and that will include the patients that are healthy and unhealthy. And if you look at 1 out of 200 might get an infection, it makes it a very small risk. But what can you and I do to try to improve that risk? So for my patients, I tell them that they need to use the HEPA shower the night before and day of the surgery to try to minimize the bacterial load on their skin, which is contribute for 95.5% of the infection. So a lot of patients think that it's related to instruments, and that's not true. It's related to the skin. For my female patients, I tell them not to shave their legs from 5 days before the operation until 2 weeks after surgery. And the reason for that, that small microscopic little small nicks that the shaver can do can increase the population of the bacteria, and that has a direct relationship to the increase of the infection. So what can I do to help you as well? Well, studies have been done extensively about infection, and what we found that the intravenous antibiotics that we give you prior to the incision in the operating room is the only antibiotic that actually make a difference. Any type of antibiotics given after surgery have proven not to be very effective, no matter how long you give it. And actually, if you give antibiotics for a long period of time after surgery, it reduces your immune system and increases your chance of infection. So what we do is we give you 2 more doses of antibiotics in the hospital. The second risk is stiffness. And that's a big deal for knee replacement. Obviously, it's a bit hard to have a patient to have a knee replacement. They're having pain and ask them to go to physical therapy and start moving around and then do their exercises. So that requires controlling of pain as well as swelling to be able to get the goal of 0 to 120 degrees, which is quite functional for everything that we do in a daily living, from riding a car or getting on a plane or sitting in a theater. So doing that is quite important. There is about 3% of patients that will fall into the stiffness phase, and for that we do what we call a manipulation under anesthesia. Primarily that sounds like a big complicated issue, but it's not really. What we do is some patients will scar faster or denser than others. So in that regard, what I tell them about 6 to 10 weeks after surgery, if they have not gotten the range of motion desired, then what we do is we take them to the hospital and we give them what we call a propofol, which is just a sleeping medicine. And we push on their leg to kind of break those adhesions. And patients find a significant improvement right after surgery, and they will continue their physical therapy afterwards. And then thirdly, which is more important, is blood clots. Blood clots does not differentiate between patient's age or sex. It comes for people that can get a blood clot and people that have low activity level. So 3% of patients will get it. We divide patients into two groups. One is a high-risk group, which means that they have a history of blood clots in the past, and a low-risk group, that patients that did not have blood clots in the past. For the high-risk group, they're going to go on Coumadin or something called Xarelto. That's a formal anticoagulation or blood thinner. And the low-risk group will go on aspirin. But both groups will use the calf compressors, which is called the plasma flow. I would like you to purchase that. And what that does, it helps squeeze the blood from the calf to send it up to your heart to reduce the stagnation of that blood and lead to a blood clot. As far as the follow-up after surgery, I tell my patients that you're going to see us here in the office at 2 weeks and at 6 weeks. At the 2 weeks mark, we're going to check on the incision, your range of motion, and renew your pain medication. At 6 weeks, you're going to have your x-ray a day or so prior, where we would discuss the x-ray position and use that x-ray as a platform for follow-up at 1 year and every 5 years after that. The surgery itself takes about an hour and a half, no matter what the procedure. If it's a robotic procedure or if it's a custom-made, it's about the same. 80% of patients will stay in the hospital about maybe 1 day, 24 hours. There are some patients that will require longer stay because of health issues or lack of participation with physical therapy, and some patients actually leave earlier. So in that 20%, some people leave the same day or they will stay a couple of days longer. Obviously, we have parameters required by the insurance company to be able to keep you in the hospital or release you. And we can go over those details in a later date. As far as what I would like to ask you to be aware of is pain control. Pain control for knee replacement is incredibly important. And it's a patient responsibility to keep their pain under control at about 3 out of 10 or less. How do we do that? One is you do it with even Tylenol every 8 hours, take an anti-inflammatory if you're not allergic twice a day, and then you take your narcotic pain medication if needed. It is incredibly important in the first 2 weeks to take your pain medication on a regular basis to keep your pain 3 out of 10. Some patients will say, hey, I don't want to take something like that, and I can endure the pain. That actually doesn't help at all, because pain itself will increase inflammation and increase stiffness, and you will be very disappointed with the result. So taking the pain medication is a paramount for the success of this operation. If you decide that this is not for you, then maybe surgery also is not for you. So this is really important for us to continue to control your pain to be 3 out of 10 or less. Other things that we would need to do, also controlling swelling. Swelling can reduce range of motion and increase pain. So how do we do that? So we do that with ACE bandage that you start from the foot all the way to above the knee. And also elevation. Using the ice machine or ice packs are very important, and doing the foot exercises to help move the circulation up to your heart, and that reduces the swelling. So by helping reducing that swelling, that also helps the pain. So a lot of people would ask me, well, what kind of activity level would I expect? Well, I give patients just a guidelines. I want you to walk 5 to 10 minutes every hour to move around and doing your exercises, and I want you to rest and keep it up, and about 15-20 minutes every hour where you can elevate, ice, and do your exercises. And I want you to do that religiously in the first 2 weeks. It helps tremendously. Obviously, falling off of that might make things a little bit tougher for you. As you can understand, people come in different shape and sizes, and their biology is very different. So you are going to study yourself and be able to tell what you can and can't do to get to that sweet spot of pain relief, reduced swelling, and improving your progress with range of motion. I really evaluate patients on which direction they're going, meaning, are they going forward, going backwards, or are they standing still as far as their progress is concerned? Most people worry about the rate upon which they progress. That usually doesn't concern me as much, and I ask my patients to look backwards 1, 2, 3 weeks. Am I better today? worse or less, or the same, depending on pain control, activity level, and endurance. So if all of them are positive, great. If 2 out of 3 are positive, wonderful. If one is better, it's still a progress. Maybe not as much as you might want, but it will get you where you want to be, maybe in a longer time, but you will get there. And finally, I want to talk to you about something really important, which is constipation. A lot of people find this funny. Actually, I don't. I think this is really important for your recovery. Imagine if you have a constipation for 2-3 days. That would affect your bowel. It would affect your pain. It would affect the way you feel. So I instruct my patients to take at least Miralax twice a day and see if they can be regular every day. To be regular is so important. So what actually causes the constipation? Anesthesia causes the constipation, as well as your pain medication and lack of mobility. All of those can have it. A lot of people will tell me that, man, I haven't eaten that much at all, so I'm not expecting to have a bowel movement. That's actually not true. Your bowels shed their layers every 3 days, so you need to have a bowel movement every 48 hours. So I start with the Miralax twice a day. If that doesn't work, then Ducalax, which is an actual laxative. And if that doesn't work, I will ask my patients to get magnesium citrate. And it's a liquid bottle, so you take half of the bottle, wait an hour. If there's no action, then in an hour, you take the other half. Finally, you will get suppositories and enemas afterwards.